Welcome everyone to this webinar on the breast cancer, regarding the breast cancer, and we have two eminent doctors, oncologists. One of them will be joining very shortly as he is attending a patient, and we have Dr. Srilesh with us. Before we actually start discussing the topic of today, I want to set the context correct. This month of October has been designated as Breast Cancer Awareness Month for the right reason, because the breast cancer is very prevalent in India, which our panel doctors will reiterate that when we start discussing this. And they have dedicated a full month to create that awareness for one cancer, that is breast cancer. That tells us exactly, how important it is for everybody to be aware of what it is, um, and prevention is better than cure, as they say. So we will try to get the experts' opinion from these doctors. First, how to prevent it, not to get it, and the second thing is that how to tackle that if one unfortunately gets this disease. That's the reason why we are having Mango Cancer Care and Mango Sciences. We actively participate in these cancer treatment options for the patients, which we will discuss a little later. And in that context, we want to, set this webinar, and I hope you will find it useful. Before I introduce Dr. Srilesh, I would like to set some, keep your, microphones in switched off mode. And as much as possible, we encourage people, if at all, whenever, especially when they're asking any question, it is better to keep their video on, so that we'll have that connection, who is asking and what is the question. And for any external patients who are going to join this call, irrespective of the language from or the state from where they actually are joining this call, they can ask their question in their mother tongue, and then we will try to translate it to the doctors in that what actually is the question, and also vice versa, we will translate the answer as well back to the patient, so that this program, which we are going to conduct more and more in future, is actually, we sincerely hope that it will really help the patients, and that's the purpose of this particular session. And welcome, Dr. Venkat. Thank you very much for joining, and you are right in time. So I would encourage people to ask questions, and also, we'll get back to them with the answers in their own mother tongue. So that would be the agenda. And without further ado, I would like to introduce both the doctors, Dr. Srilesh and Dr. Venkat Sampath. Dr. Sampath is actually, he's an MD and DM medical oncology. So he's a super specialization in medical oncology, and he practices, is one of the very busy practitioners in one of the leading hospitals in Hyderabad. And Dr. Srilesh also is a medical oncologist, and both of them actually came out of very good, reputed medical schools in India, and they have got certifications abroad, all the cancer related things. So they're very, very experienced in this, practicing more than 10 years in this field. And breast cancer is one of their specialties, as you can see, and that's the reason why we have Dr. Srilesh as well as Dr. Venkat Sampath on this call. Welcome both of you, Dr. Srilesh and Dr. Venkat Sampath, and we really appreciate your private time. This is about 7 o'clock at your place. And my name is Dr. Subramanyam. Everybody calls me Subbu, and you can address me going forward as Subbu. So I will be moderating this particular thing. So with that set in, I would like to go with the first question, being the Breast Cancer Awareness Month. Dr. Srilesh, can you just explain to me what is the prevalence of this particular disease in India? I would like to focus more on India, and especially in South India, since both of you are actually practice in these places. And how does it look, and the numbers, in terms of numbers, is it increasing? and then we will take up if it is increasing, what could be the reasons for that.
Good evening, sir. Good evening. Yeah. First of all, thank you, Mango Sciences, for inviting me for this discussion. So basically, breast cancer is a very common disease. If you see the global statistics, it is one of the common cancers in females. And if you see the Indian statistics, particularly the ICMR data, that is one of the leading research team which actually compiles all the data from all over the India. So they also say that breast cancer is one of the commonest cancer in females. And also, if you ask me about the South Indian registries, you have in my state, that is in Kerala, you have this Trivandrum registry, you have this Kollam registry, and you have three registries in Kerala. And if you see their statistics in 2020, you can see that it is roughly around 28 to 30% in women. Among the female cancers, around 20 to 30% are breast cancers. That means every third patient will have breast cancer. And also in our routine OPDs also, I had just an OPD today, and if you see every third patient, at least one will be a breast cancer. Some of them will be a new patient, some of them might have already taken treatment, or some of them will be in follow-up. So it's a very common disease. So if you see the prevalence, and usually it is seen in elderly age group, more than 50, because as the age increases, the risk of all cancers is going to increase. But nowadays we see a trend like around 30, 40 age group, the incidence is increasing. Maybe due to multiple factors. And even I have a patient aged 19 years who are even not married. So localized disease. So basically it can affect any woman, but it is commonly seen in elderly patients.
Yeah,
Among in
that's
Kerala,
very.
I think it is, yeah, among
Yeah,
Kerala,
go
I
ahead,
think
go
it
ahead.
is Kerala, I think it is the incidence is even more, I feel. Maybe we don't know the reason exactly, but we say that we have high life expectancy. That may be one reason.
Mm.
Sometimes our diet may be the reason. So
Mm.
again, sometimes because nowadays we have facility for testing. We have previously 10 years back, the facilities for testing and consulting doctors were not very easy. But now we have so much of facilities in every part of our, I mean, state. We have mammographic centers. You can do biopsies, and also the awareness among the female actually increased because of our continuous education like this. So that may be the other reason why this is increasing. But
Mm.
one thing I noticed is that it is good for our patients because previously, when I was doing my DM, that is 10 years back, we used to see a lot of locally advanced ulcerated, even metastatic disease. But nowadays, such incidence is actually less. Maybe because
Mm.
I am working in a premium hospital like Aster, maybe that may be
Mhm.
the reason because we see only that kind of patients. But
Mhm.
roughly, when we're going for meetings with my colleagues from the government medical college, and they are also saying that the advanced disease, especially the ulcerated fungating as well as its metastatic lesions, are comparatively less nowadays.
Less.
That is good. That is good. Maybe because we are doing a lot of awareness program. That is the idea of this Pink October. Basically, we want our women as well, all even men to know about this disease, early
Mhm.
diagnosis. Because the advantage of early stage one breast cancer, the cure rate is almost 95%. So your treatment intensity will be less, the less treatment for a stage one disease. So all because we need to spread the awareness. That is the main idea.
Excellent, sir. Thank you very much.
Yeah.
And Dr. Sampath, do you want to comment on that?
Yeah, more or less it is same. When the Globocon data and all say that breast is one of the leading cause of incidents. In incidents, it's one of the leading. But mortality is not compared to other cancers. We have done very good improvement in terms of
Mm.
saving their lives. It is because of advancements in all fronts in terms of surgery, radiation, as well as chemo, immunotherapy, target therapies, hormone therapies, etc. But for instance, is breast cancer is like an index for urban population. Like in urbanization, modernization is being reflected in the term in terms of breast cancer, colon cancer, etc. So our lifestyle is reflecting in the terms the incidence is increasing. The prevalence corresponds to the incidence. However, the survival rates have dramatically improved, and the long-term surviving patients are there because that second cancer incidence in the opposite breast and re-recurrences of a second primary in the if BCS is done. So this kind of statistics also are accounting for for more incidents.
Very well done, and thank you very much for that. And now coming to the that is the numbers are we know that the numbers are increasing. And what I would like to know is that if the numbers are increasing is there any specific population like millennial population, or is it you will be getting patients from the rural areas, you will be getting patients from the urban Hyderabad and Calicut and Trivandrum and all these cities, and you get population of very village population, not so educated and conventional living, and they have been living like that for so many years, versus people who are modern, this millennial population, who have their own views about marriage, getting children and all that stuff. Do you think there is any particular specific thing that you can draw saying that this kind of a, because this is very important, I wanted to ask this question, I want people to know about it. There are certain windows in life that you have to complete some certain activities, and that is really because that is actually superimposed with the hormonal activities that a person has got, and hormones have got a very significant impact on female cancers, whether it is breast or cervical or ovarian. And I would like you to comment on that, both of you, because that's very important. In addition to lifestyle, etc., lifestyle, they get a lot of material to read and stuff like that. But in terms of their attitude, in look towards life, and what is important and how that is going to impact them in their future life. Because doctor mentioned that there is a 19-year-old, and even if it's 30-year-old people, if they are marrying now, if they get into, if the incidence is going to be increased, that's going to affect their motherhood, their whole life after marriage. So I would like you to take up that particular thing and comment on that. Dr. Sampath, you want to go first?
Yeah. So as already mentioned, urban population, it is quite high compared to rural population. This is mainly because of certain factors like obesity, eating more of junk food, westernization, eating less fiber food, less exercise. Stress is one of the main contributing factor. And so there are certain factors which are like we can divide it into modifiable and non-modifiable. So among non-modifiable factors, genetic history, family history contributes significantly, especially in women with a lot of family members having the history and having BRCA1/2 mutation positivity, the chance of recurrence is more, chance of incidence is more. And there are certain factors such as early menarche, late menopause, because of exposure for estrogen for a longer time of the breast, mainly hormone positive breast cancer chance is more in such patients. Nulliparity, not having, marriage, late marriages, late childbearing age, and all are found to have the chance of higher incidence. But more than that, the lifestyle factors are quite important because these are modifiable. One can, do good exercise. One can prevent obesity. One can have good. One can take a lot of fiber food and fresh vegetables and salads and all. So those factors may contribute to decrease in the incidence because it's the same urban population who have all the education, who have all the awareness, who know that what a painless lump could be, and who visit the hospital regularly, and who have all the resources at their stake, who can come to, who have insurance and everything, who can have regular health checkup and all. Despite that, the incidence, they should not, at least screening and all should be good in this population. So that's why we are able to detect early and treat well. In rural population, the problem is they come at an advanced stage to us because of lack of awareness. I think pain, only once pain is there, that has to be worried. In painless state, the painless lump they neglect, and that can go to the stage where it has spread to axilla and other areas, metastatic sites like bone or lung and brain and all. So this is what basic premise is. You're not audible, Subramaniam, you are not audible.
Dr. Srilesh, can you take, thank you, Dr. Sampath and Dr. Srilesh. Can you also comment on that, please?
Yeah. And like Dr. Sambath said, basically, previously breast cancer was considered a disease of developed world, like US, UK, but that is not true now because nowadays we also see almost the statistics is almost like Western world. So, like Dr. Sambath said, urbanization is an important factor. So, if you see the causes of breast cancer, out of 100, 10 will be less than 10 will be genetic. So, we cannot do anything about it. Like I said, the 19-year-old patient that I had, actually, her mother was a breast cancer patient. Her elder sister had an ovarian cancer. So, basically, she was a genetically prone cancer patient. Like, patient had a BRCA, BRCA1 mutation. So we can do nothing about that because that invariably will come. We have certain options to prevent that, but 19-year-old options are very less. The other thing about is regarding the diet, lack of physical activity, because this lack of physical activity has inherent effect on the hormonal milieu, hormonal influence on the breast. Then nowadays, usually the marriage age is usually like slightly late, usually 30s. So less child, less breastfeeding. So these are all protective. Breastfeeding, late men, I mean, parity, all these are protective basically for breast cancer. But now because of the nuclear thing, we are going less children, less milk. So that's the reason one. Then of course there are some cases we don't know the reason actually. If you get older, you will someday you will get cancer. My professor used to say, if you are past 70 years, there is a 1/3 chance that you will get a cancer, or 1/3 chance that you will get a cardiac event. So that is true. As the aging population increases, definitely the incidence is going to increase. But the problem is that the thing is you have to dictate it very early, because breast cancer is a very easy to dictate thing. Like it is an external organ, not like lung cancer where you don't have any symptoms, you don't see anything. But breast cancer, even the female patients usually can dictate. So most of the patients that comes to my OPD are actually dictated by the patient only, not by mammographic screening or not by the doctor. So even the patient can itself dictate. That is the one advantage of breast cancer. If you dictate it in a stage 1, your treatment is going to be very less, your duration of treatment is going to be less, the cost of treatment is going to be. That awareness we should actually tell our patients. Again, another important thing is that the problem is most of the patient usually comes to hospital because of the pain. Like Dr. Sampath said, pain is a late symptom of breast cancer. Initially, there won't be any pain, there will be just a swelling. So, the self-awareness of breast lump, we should always tell our patients as well as the female population. So, that's what I think.
Thank you very much, sir. Now that we have got some idea about what is the incidence and what could be the factors leading to this increase in the breast cancer, etc. Let's get to while we are doing this, this is a preventive thing that so far we have discussed how people can prevent it by following good lifestyle and following other things that you have mentioned. Now let us get to those people, unfortunate people who actually have got this disease. But the good news is that it is curable if it detected early. That's what you have been telling. I want to go through the journey of this treatment of breast cancer, right from chemotherapy, because cancer therapy, cancer research in pharma industries is given the highest priority and highest dollars to ensure that you get better and better medicines, not only to get a better outcome, but also to reduce the discomfort for the patient. So I want you to you to comment on that journey so far from the pharma industry in terms of why they are getting into, what is that they are looking for, and where we are today and what could be the future. Dr. Sampath?
So basically, once a patient with breast cancer is diagnosed based on imaging and biopsy is done, the most important thing is
Dr. Sampath, maybe you can your voice is you are very far off from the microphone, I guess.
yeah. I'm audible now.
Yeah, better, I think. Yeah.
So basically, once the patient is diagnosed with imaging and biopsy, the most important thing is molecular profiling of the patient. So staging is done parallelly with to know whether the disease has advanced to other distant areas or not. If it is not so, the molecular profiling is most important in terms of early locally advanced as well as metastatic disease. So in molecular profiling, we know whether patient is hormone positive, HER2 positive, or triple negative. Basic in hormone positive luminal A, luminal B. So based on that, our treatment is decided. So in HER2 positive, which was erstwhile bad disease, wherein the survivals were dismally poor, like especially in metastatic stage 4 patients of HER2 positive disease, the survival was like 5 years ago less than 20%. But now with the advent of anti-HER2 treatments, there have been rapid developments in terms of anti-HER2 target therapies and also drug monoclonal antibody conjugates such as trastuzumab, then pertuzumab, TDM1, that is trastuzumab with DM amitriptyline 1 combination. Yeah, then we have trastuzumab deruxtecan now. So there are so many options. So because of that, survivals are quite good in even stage 4 patients. In early stage patients, we are reaching definitive cures in more than 60-70% of the patients. Even in hormone positive patients, advanced stages, without surgery in metastatic patients, we are prolonging beyond 5 years, 10 years with CD4K6 inhibitors, especially in patients with no liver mets, etc. And in triple negative patients also, we have immunotherapy and other advances. So there is something called low HER2 positive or low expression of HER2 in such patients also with monoclonal antibody and HER2 antibody drug conjugates. We could improve survivals. So there is a very good advancements in terms of research from the pharmaceutical side. Only thing is we want cost advantage because these are all in their early patent stages. To get to the patients, that kind of benefit will take time. So we need innovative thinkers who would try to bridge this gap and improve the financial paradigm. There are many assistance programs, but still they are not able to reach to majority of the patients. So this is a very area which is lacking sufficient resources and all.
Thank you, Dr. Sampath. And Dr. Srilesh, you want to comment on that?
So again, if you see the evolution of treatment in breast cancer, you can see that the surgical aspect has come very big way. Then radiation technologies, radiation techniques has improved a lot. And of course, the medical oncology side has also improved. So previously, maybe some 150 years back, the surgery always was a complete removal of the breast as well as the muscle. So it was a mutilating type of surgery. But we have improved in such a way that nowadays you won't even see the scar. So even if you remove the complete breast, you can actually reconstruct it. So that is the way the surgical oncology has become modernized. Similarly, the radiation. Actually, radiation was started in 90s, I think, early 90s, 90s, 90s. Röntgen discovered X-ray. After that, the radiation came. Again, the previous radiation were again mutilating type of radiation. Nowadays, you have this 5-fraction radiation, you have 15-fraction radiation. Again, the developing technology has improved the outcomes, both quality of life as well as the survival. Similarly, of course, the breast cancer, I mean, medical oncology side has also improved very much. So basically, like I said, so if you see a breast cancer patient, we had to say which stage it is. Basically, very early stage. Sometimes will be early stage will be easily curable with less treatment. The second group will be locally advanced. You will have breast mass as well as some axillary nodes. Again, that patient is also curable, but you need more treatment for that patient. And of course, third group of patients are there where the breast cancer also already spread to other part of the body, like lungs, brain. So in that case, it is not curable. So in stage 4 or in metastatic situation, the idea of treatment should be prolonged survival with a good quality of life. Whatever you do, you are going to cure the patient, but you have to improve the survival with a good quality of life. But in stage locally advanced disease, we need to give all the treatment, maximum possible treatment, so that their survival should be good. In early stage disease, you can actually de-escalate treatment, some minimal treatment. So, like Dr. Venkat said, you have different molecular features. Suppose you see two patients, same age, you see 2 centimeter breast cancer, no node. Hello?
Dr. Sampath, maybe you can go on mute, sir, to reduce the noise.
Yeah, it's fine.
Thank you. Thank you.
So if you see two patients, one patient, suppose patient 2 centimeter lesion in both patients, so one will be having uh, a good prognosis when compared to other patient. But they're both breast cancer size, age, everything, treatment, everything is same. The main issue is their biology. Some patients we may require more treatment in the form of anti-HER2 therapy, immunotherapy for the maximum survival. But some patients can get away with just tablets like hormonal therapy. So in order to that way we have come in a long way, especially in HER2 positive setting as well as triple negative setting. There are so many drugs available to improve the survival. But problem with us is that the money is going to be the issue. So if you see the survival of patients in the UK or US compared to India, survival is going to be less in India in locally advanced setting, mainly because of the non-availability of these drugs. Not non-availability because of the accessibility. Because majority, at least in my practice, the patients taking anti-HER2, dual anti-HER2 agents will be restricted to those with good insurance or those with some ECHS facility or ESA facility. That is the reality. Most of our patients, middle class patients, won't be able to afford all these treatments. That is the main thing that we should be concentrating.
Yes, you hit the nail on the head. That's very, very. Both of you actually have. I just wanted to paraphrase it for the benefit of patients and patients' caregivers. The situation in terms of the technology or the research that has been done has taken us, brought us to this level where there are drugs available, and which depending on the stage at which the breast cancer is detected, they can be used and the outcomes are predictable, I would say, and so that we can with confidence say that yes, this can be 95% it can be cured. That's very good. So the all the patients and the patients kith and kin, they have to understand that the technology has improved quite a bit, and some of these drugs are available even in India, and the only thing that is coming in the way is the cost, affordability, because just because they don't have money and they can't afford a particular drug, even though it is available in Indian market, they are not able to get the treatment. And that's very well said, sir. And so what could be the, because Mango Sciences is very much, that's a problem that we would like to address, as and most of the patients, we would like to mention that we are trying to bring down, not I don't bring down, because we don't have any control on the price of the drug that the pharmaceutical manufacturer will do, and we're trying to avoid that, and we try to ease that pain of sudden burden. The main issue here is that each treatment, the dosage cost is prohibitively high. Now that is a killer for the patient. So we're trying to spread it over a period of couple of years, so that that onslaught of that sudden expenditure of few lakhs of rupees at one shot, um, probably we're trying to see that whether it can get reduced with the help of the doctors whenever a particular drug is prescribed for the patient. So what are the other things that you think that companies like us can actually bring in to ease the patient? Because I want you to be on the same side of the table as we are, and we have a common problem, and all of us are interested in getting our Indian breast cancer patients to get the global treatment, global standard treatment of highest standard available to them, and not deprive them of this particular global standard treatment just because they don't have money. You can be very candid on this, both Dr. Srilesh and Dr. Sampath. Dr. Srilesh?
Like I said, sir, basically the issue is cost. These drugs are readily available, but most of the time we are not able to give to the patient, because majority of, at least in my practice, are middle class or very upper middle class families. because the trastuzumab pertuzumab combination may cost you around maybe double-digit lakhs per year. So that, and like you said, the initial cost is going to be very high because initially we need to give the loading dose, and again, even though pharmaceutical companies have come with some some PAP program, patient assisted program, still cost is an issue. Again, like the Mango Sciences previous program of osimertinib, I think that past 1 year it has helped a lot of my patients. So previously they never used to take osimertinib, but now I have 4 or 5 patients actually on this program. But again, this I think same kind of I don't know the exact PAP program for Perjeta, but again I think this is going to be helpful for the patient. But again, the money issue is still it's an issue. I don't know how we can.
Any thoughts on that, Dr. Sampath?
Yeah, I agree with Dr. Srilesh. What I would say is Mango Science is doing good in this area, but I mean the research is so fast that by the time one molecule we are about to be happy, a new molecule is coming. So you have to catch up in areas, especially like pertuzumab is a good initiative, but Pedgo is a reasonably good option already available, and the deruxtecan is already there. So in every area, I mean, one can pick up that will be good, and you can tie up with corporates for corporate social responsibility funding and crowdfunding, because this is a good initiative. So that in addition to whatever you are helping in terms of making it into EMI, you can help patients in terms of cost also to some extent. That's what I would suggest.
Okay, very well said, and I think we are already we have 15 minutes time left, and I don't have any more questions except that Upasana, you want to open it up for question and answers? As I said that people can ask in any language. We'll ensure that you'll get the answers translated into the local language. We have people here who know who can speak most of the languages in India. So, any questions from anybody? Okay, just I wanted to have just one more comment. Yeah, while the research is going on new molecules and conjugates and other stuff, and you also both of you touched up on the genetic testing. Now that with NGS and all these things coming in, and when do you think that particular thing will actually percolate to the tier 2 and tier 3 cities as well? Because that's another thing. Testing itself, NGS really complete panel testing is again very, very expensive. Before you actually decide on whether the particular treatment is going to work or not to work, that itself is a killer. It is going to the patient has to spend a lot of money, and at the end of that whole thing, and I also want to know that what is the awareness of because I'm basically a geneticist, and I know about genomics and this thing, and it throws out a lot of information, and you have to really find out what exactly you require from that whole thing. So what is that? Where do you think we are on that particular genomic testing, and how we can make it quick and more relevant at this point of time? If you go to I don't know foundation, they will send you 25 pages report, and you have to really search where actually the answer for your patient is within that. So how do we solve the problem, and where are we and where actually we are going to go to in future, sir? Dr. Srilesh?
So, like you said, sir, reading a NGS report is very difficult for us because it is very difficult sometimes. Sometimes a lot of mutation. I don't know how to interpret it. So basically, what we did in our hospital is we basically conducted molecular tumor board every month, where geneticists involved, pathologists involved, and we actually have a discussion. So there are certain molecular test report that we can go away. So there will be some like PIK3CA mutation in a ER positive breast cancer progressing after some treatment. You have this molecule against that. But in certain situation, you won't see the common mutation. You will see some another one never heard mutation. So in that case, it is very difficult. So basically, in our hospital, we conduct molecular tumor board. We have started this for the last 1 year. So that's what we do. And again, the genetic testing, there are two implications actually. One is, of course, the treatment part. Second is actually the family screening part, especially the genomic level testing. So previously, we never, when I was doing my DM, when I was doing my DM in RCC, we never does that test because it was not so prevalent because there was no treatment implications. But nowadays, we are legally bound to test all this because there are some patients who will benefit from PARP inhibitors like post to prevent recurrence. There are three. So if you don't do, sometimes you may be in trouble. So today, usually majority of the patients, except in HER2 positive patients, we send the patient to the genetist here. So she does the test, at least BRCA1 and 2. So that's our policy. Again, this somatic NGS, like you said, it is always difficult. Especially this usually comes when there is not much options left. Like in heavily treated patients, there is not standard options left. So we usually do this NGS and we interpret in a molecular tumor board. That's what in our hospital we do.
Dr. Sampath.
Yeah, like somatic NGS in metastatic cases we do, and as you well rightly said, foundation medicine was initially the go-to place, but now there are many options. The only thing is they are not standardized, and like we have 30 to 40 options. I mean, there are many labs nowadays coming to us and all. So we don't know whether they are how good they are and all. They give sample reports of other patients and all. So basically, to read the report, we focus on whatever mutations which are positive because they give the data regarding every other unnecessary mutation also. But the most driver mutations, we need the information. And is it targetable? And how common this variant is? Is it of significance or it is of unknown significance? So based on that, in patients where we have exhausted standard options, we could use targeted therapies. As rightly said, in HER2, HER2 we don't go upfront, but in hormone positive patients who have progressed on CD4K6 inhibitors, for PHCA mutation and other mutations, it will help. Some rare mutations in 1%, 2% of the population could be picked up. So maybe it's good to do universally, but the cost has to come down further and the standardization protocol should improve. In tier 2 tier 3 cities, it's going to be even more challenging because even in places like Hyderabad, the turnaround time is quite long, around 15-20 days. So, because they usually send to other places like Mumbai or Delhi, most of the labs, only few labs to locally.
I think that's very interesting and very, yeah, I think we have to move forward quickly on that because, you know, in the Western countries, without, you know, I'm right now in Germany and I was talking to some, you know, doctors here. So without the genomic panel, they don't touch anything. They don't start the treatment at all. That's what they say. They can afford that, but I don't think we can do that in India. But that's very interesting. And before we leave, if there are no more questions, do you really honestly believe that the kind of initiative that Mango is taking up to help the patients who are actually in targeted and immunotherapy, which are high cost therapies, to help them out, is this a good initiative that our country requires? With that comment, I'll take your leave and thank you very much for that, sir. So any one of you or both of you can actually answer that question. Do we require our patient population, do they require such programs?
Definitely, sir. I think such programs should always come up. Like I said, the osimertinib program was very good, but I think that was suspended. I think I don't know why. I think this kind of program should be there, at least for Indian patients. It should be there.
Dr. Sampath?
Yeah, I do agree. I was very impressed initially, but somehow even with that kind of program, it's difficult to push the patient. We ask them to approach, but somehow they really dally. But this approach is very good actually, and they also want to proactively participate in this kind of support.
Yeah. Thank you very much for your personal time, and we would like to see you again sometime soon. Thank you very much,
Thank
sir.
you.
And thank you, our audience, for all your for this thing. And if there are any more questions, you can always reach out to us and we'll try to get back to you. Thank you, and have a good one now. Thank you. Bye bye.
Thank you.
Thank
Thank you.
you.
Good
Good
night.
night.
Good night, sir. Good night. Good night.